Great. So I think, I know I was here yesterday afternoon and had the good and great fortune to hear my colleagues speak about sexual health and sexual function yesterday. I think we all can roughly agree that this slide in many ways captures the experience for the majority of our patients, which is that it really is the elephant in the room for so many of our patients. People really struggle with so many aspects of disruption in terms of sexual health and sexual function, and we really don't talk about it very much. That being said, I really want to think together about what the take-home was from yesterday's talk and what we need to think about in terms of moving forward for steps for intervention and building programs. I think we can also sort of, again, thinking about yesterday's talks, agree that sexuality really needs to be more broadly defined. We all have a sort of preconception about what sexual health or sexuality means to us, but thinking about this for our patients, I would say that taking the broad view, where we really think about what is a life-affirming experience throughout the lifespan, and really just appreciating from the get-go that this is not just about what we do or our behavior, but it's also as much about how we feel, our identity, our motivation, our experience of self and relationship. And it is always in a context. I think Dr. Stryker mentioned that yesterday. You know, when somebody walks in the room post-cancer, they have a sexual history and a sexual past that we probably need to know about in order to figure out, one, what is baseline, and two, what the hopes and expectations are for where we are moving ahead. So I'm not going to spend too much time on this because we again spoke about this yesterday, but just to say that beyond the fact that this is probably one of the most enduring challenges after cancer, and I underscore that because this is not a problem unlike many other problems which get better by themselves. This is a problem that typically gets worse over time, not better. It's also an issue that for patients, people don't feel prepared about it on the front end. The majority of our patients hear very little about expectations and concerns about how sexual function may change vis-a-vis treatment, vis-a-vis survivorship, and we really owe it to them to give them that framework going into treatment. I will also say that in contrast to cancer treatment, and again, we know that all of our treatments has the potential to impact sexual function, I also want to just mention fertility treatment. We also can really sort of think about the enormous sense of collateral damage related to fertility treatment that does not get discussed. So certainly if anybody has ever tried to make a baby in the context of sort of having it be sort of a military campaign, you might have experience with knowing that that has a really big impact on the experience of sexuality and pleasure. And that certainly, I know Dr. Nelson's group has done some of this work looking at sort of implications for sexual health and psychological health and well-being in the context of infertility, but that it really matters when we're talking with our patients about fertility treatment, whether it's fertility preservation, whether it's actually going through IVF later. The whole range of ways which we sort of try to recover fertility also can have a real impact on how couples talk to each other, on how people feel about themselves and their bodies, and this is very much a part of fertility that really needs to get addressed. I'll also just note that in the context of cancer treatment, think about this as a real double whammy. So if you're going into fertility treatment, you've already gone through a cancer experience, you already have a sense of feeling perhaps damaged or different in some way in terms of your physical function, and now you also have to think about sex in the context of it being something that is routinized or instrumental or goal-oriented. It has real implication for increasing relationship stress and decreasing intimacy. Also, I think we need to be aware of the risk factors for who is more likely to be struggling with sexual function later. Certainly, when we think about the sort of big numbers, 50 to 80% of people have sexual dysfunction, we can't just use a broad brushstroke, but it's helpful to think about who might be at greater risk. So certainly, if you are seeing somebody who has a history of relationship issues, of relationship stress or sexual problems, if you have a young patient or middle-aged patient that is struggling with physical function, struggling with fatigue, or struggling with loss of energy, most likely that's also going to get played out in terms of sexual function. So really, in many ways, the recommendation we give our clinicians is that if sexual function or sexual relations have not returned to a kind of a normal level within about a year after treatment, we can assume that there's some kind of long-term disruption, and it's really important at that point to clarify whether somebody is having any bother or stress or discomfort and wants some help with that. Also want to point out that when patients are younger, when patients are single, often we assume that it's not as big a deal, and it actually often is a bigger deal, right? So when we think about what that means for somebody who is trying to contemplate, how am I ever going to meet somebody? What does it mean to date after cancer? How am I going to find somebody who's going to want somebody damaged like me? Obviously, that's in play. And then I really want to think with you about this idea of our younger patients and thinking about the range of treatments that we offer people in order to cure cancer that really have a very profound impact when somebody is, at sort of a younger years. So whether that's being an adult survivor of pediatric cancer or an adolescent young adult cancer survivor, it's something we need to think about. So one example I want to give are our BRCA mutation carriers, because this is a young population. You may deal with these folks in the context of thinking about fertility, but I want to sort of give that sense of an overview, because this is really where we see issues around fertility and sexuality are very much overlapped with each other. So certainly we don't typically recommend BRCA testing. This is let me sort of step back. BRCA mutation, meaning breast cancer mutation, identified that puts women at very increased risk for both breast cancer and ovarian cancer. We don't typically do testing until women are about 25 or within about 10 years of when they had a first-degree relative die of cancer. But typically these women are young, premenopausal, single, may not have had children, and it's a pretty stark choice. So we know that when we do risk-reducing oophorectomy, that is, we remove the ovaries, we reduce ovarian cancer risk by 90%. That is unbelievably significant. It's also the best bet in town because we do not have screening for ovarian cancer. So in contrast to something like breast cancer, where we can offer very close screening, we don't have that for ovarian cancer. We also know that women can have bilateral prophylactic mastectomy. We certainly see this in the media. Angelina Jolie has given an enormous amount of sort of public support for this and education. Again, reduces breast cancer risk by 90%. So current recommendations for this group of women is to have ovaries removed by age 35 or after you're done with childbearing. So if you think about it, 35 is a very young age to go into menopause. This is also not a natural menopause. If you've ever had the experience of speaking with somebody who's had their ovaries removed surgically as a young person, it's kind of like driving into a tree. It's kind of like driving off a cliff. This is not an experience of adjusting in sort of perimenopause over many years. So to give you a sense of the kind of decisions women face, clearly the thought is that you really need to do this to save your life. Often women describe that sense of a Damocles sword hanging over their head and the feeling of having really not a whole lot of choice, knowing that they need to do this kind of surgery. But this gives you a sense of some of the comments that we've heard in focus groups we've done with women after prophylactic mastectomy, for example. My partner says my breasts look great, but my nipples are totally numb. I think Dr. Lindell spoke to this yesterday, how we spend an enormous amount of time and effort and energy doing incredible work around reconstruction. But for women, it's really just about how it looks, but you don't feel anything. You have no breast tissue and no breast sensation. And if, for example, having nipple sensation is the way that you have orgasm or arousal, and that's just gone, that is a profound shift in one's sexual landscape. I can't feel anything from below my belly button to my neck. How's that for sexy? Okay, so this is a woman that had a flap surgery, used her own tummy tissue in order to sort of do reconstructive surgery, but in this case had no sensation from here to here. I hate the scars. They remind me every day that these breasts are not real. And again, lastly, a comment that we hear over and over: I'm grateful to be healthy and I try not to focus on it, but my breasts don't feel the same. It really changes how I feel about myself, especially when it comes to dating. So that gives you a sense of the kinds of compromises people really have to make at a young age in order to do life-saving surgery. So similarly, now couple that with what it means to also go into menopause around the same time. Women don't feel prepared for that, often will say something like, a real quote, "I had no idea that I would feel that I'd been neutered. My libido's gone and I just don't feel much at all." Now, to be frank, that is a pretty harsh quote. That's a stark sentiment. I also understand why surgeons are not keen to say you're going to feel neutered, right? That doesn't really sell the surgery. You're going to reduce uptake of potentially a life-saving treatment if we sort of only stress the downside. On the other hand, if we don't give patients the message that there's actually something you can do about it, which is really where the focus of yesterday's talks were at, then they miss the boat. Right? Then we don't give them the benefit of saying there's going to be something that's different, but we know what we can do to help preserve sexual function. And similarly, last quote, "I feel bad that it takes so long to get aroused. I always worry that my boyfriend will get tired and just think I'm old." So it's interesting from the point of view of doing couples work, and often I see patients and couples together, how often a woman will say, "I am embarrassed about how long it takes me to sort of get where I'm going," right? Arousal takes more stimulation, it takes longer, and I'm just assuming that my partner is thinking, "Oh my God, this is taking forever, I'd rather watch the baseball game." When actually, if you ask the partners are like, "You know what, I'm like really happy to be in the game with you." Right? I'm not watching, I'm happy to be here. But if that couple has never been able to communicate, right, about what's going on within that dynamic, people really have very different ideas about what's happening in the room. So I have to just include this because these are the kinds of comments that I think many of our young women hear, both from not just their manicurist, I think we heard one yesterday, but sort of in popular culture and from their clinicians about what you do about any of this stuff. Again, real quotes. "I did mention that I hadn't had sex with my husband in almost 4 years, and my gynecologist told me that I should consider having an affair. He said it might shake things up a bit. People keep telling me that I should have a glass of wine and loosen up. I was told," I like this one because I hear this again in many iterations, "I was told to try watching some porn, but I just felt worse about my body," right? So, porn, I will say, is the sort of visual fantasy of an 18-year-old, which may or may not be arousing for some women, but for many women who are dealing with major body alterations, it's not helpful. It just kind of reflects back what you feel sort of more damaged about. And I keep hearing use it or lose it, but I just don't know how to do that because sex hurts so much. So given all of that as the backdrop, we have to do something about it. And we need to be able to figure out in a systematic and methodical way how to create a program of sexual renewal for folks that will be integrated, that will really bring together a focus on the kind of the bio, psycho, and social aspects of their experience, and to be able to figure out with our patients, where is the barrier? What is the damage? Not everybody is struggling with the same thing. So it may well be that I had a patient just last week who said to me, "Actually, my husband is awesome. We actually do lots of other kinds of sexual activity. I'm totally turned on by him, but I can't have sex because it hurts so much," meaning penetrative intercourse. And again, we heard yesterday about a number of women who will talk about the fact that because intercourse hurts so much, sort of everything else gets turned off and they kind of look away completely. So it is not one-stop shopping. I think what's really important and incumbent on us is to figure out what aspect of which domain is changed or different and what we need to do to intervene. So in terms of our model, I think you have to start with the body. I think this is very consistent with what we heard from Dr. Lindau. We have to figure out what are the mechanics in terms of treating pain and discomfort. I think we need to really think about self-care in terms of diet and sleep and exercise in the same way with sexual health. This should be on the same list. It should become a sort of part of the same review of systems and conversation. And appreciating that for our cancer patients, learning to be in your body without feeling panicky is not obvious. Learning to be able to be in the moment and fully present to your physical experience is not easy. If you feel that you have been damaged in some way, if your sort of basic proprioceptive feedback often is something that raises concern about, do I have cancer again? Is that a lump or a bump I have to be afraid about, right? When you feel that you've had invasive treatment and what you've had to do in order to understandably get through that is to dissociate from your body in certain ways. It's not so obvious how to then be fully in your body without feeling panicky. That is something that we have to address directly as part of renewing sexual health. So I'm not going to talk about menopause and vaginal health because I think we talked about that a lot yesterday, but I will just say this. I feel very strongly that we talk about vaginal health in the same way that we talk about sexual health. And I use that word with patients. I say to patients, we think about vaginal health the same way that we think about bone health or your brain or cardiac health, and that's related to sexual health, but it's not the same thing. Right? That whether you are sexually active or not, whether you are married, divorced, young or old, you need to know what you need to know to keep your body healthy, including your vagina. And that is just a part of how we talk about self-care. This is the slide that we also show patients. We talk about it in a very sort of, we try to distill it for patients to say, what do you need to do to have a healthy vagina? You need moisture, you need stretch, you need blood flow. When you go through early menopause and you have a dramatic loss of estrogen, you have a lack of these three items, these three elements, and we need to restore those. And we sort of go through the kind of the functional steps about how to get there. And then again, we need to really put this in a larger framework. So I know that we heard yesterday from a number of our colleagues that said, I use an ASECT therapist. I have a list of sex therapists, go to ASECT. I'm not against ASECT. ASECT is an awesome credentialing organization that does work in sex therapy. But I will say this, not everybody who is a sex therapist has any idea about cancer. Not everybody who's a sex therapist knows about some of the elements around fertility and oncofertility. So I would just say, as a psychologist, being a little bit more nuanced, I think it's really important that you think about your behavioral provider, your sexual health provider on the psychosocial side, as carefully as you might also think about your medical provider. I think that because someone is just sex therapist, it doesn't necessarily mean that they're going to feel comfortable or competent dealing with this sort of oncology or oncosexuality piece of it. And it's important to find somebody who has that both interest and training. In terms of the psychosocial framework that we use, it's a tripartite model. There are really three elements of that. One, we're sort of guided by self-determination theory, which says that we really need to sort of promote autonomy, competence, and social relatedness in order to sort of have a sort of both sustainable quality of life, but also in terms of promoting behavior change. This is not a sexuality theory or an oncology theory. This is really a theory in behavioral medicine and psychology, but these elements are critical. People need to feel that they have choice, people need to feel that they are competent, and people need to feel a sense of connection, right? And all of those elements need to be in place in order for behavioral change to be sustainable. We also use a mindfulness-based cognitive framework in order to help people move away from a sense of sort of avoidance and distraction to a place of sort of greater acceptance and awareness in a non-judging framework. Now, again, that sounds easy. It's something you have to practice. It's something people have to learn. When you're sitting in bed next to your partner, whether you're actually touching or not, and you have a tape loop running through your head, talking about all the ways in which things are not the same, they'll never be the same, you wish you were dead, anything would be better than this, you have to have a way to address those thoughts. You have to have a way to sort of notice those thoughts and have a greater sense of compassion for yourself, because if you don't, that is going to be a major barrier in terms of anything that you're going to do physically. We also then use a sexual rehabilitation therapy framework, also from a mindfulness perspective. So similarly, taking that kind of non-judging body awareness. Again, Dr. Lindell's fantastic talk about the pelvic floor, right? All of that is amazing, also premised on the fact that women can and are able to sort of be in their body and hold those sensations and feelings without feeling panicky. Some women are able to do that more easily than others. Some women need some coaching and support, but it's critical to offer that if women need it. And then there's the relationship piece. Again, this is not a minor detail. For folks that are either in a relationship or not in a relationship, whether it's previous relationship or current relationship, has enormous impact on people's capacity to move forward and through sexual renewal. So we will often, as needed, incorporate a partner into treatment. We certainly do couples workshops at the Dana-Farber through our sort of adolescent and young adult program and our young women's breast cancer program. And the idea here is that partners really don't have any idea what to do to help. So I would say, in general, if you're seeing a young cancer patient partnered, you can bet that the partner often really needs some help. Often we sort of see that typical dynamic stalemate where partners don't want to seem like they're being pushy. Patients experience their partner as sort of staying away because maybe they're not attracted to them anymore or they don't want them anymore, increasing that concern about desirability, when the partner's just trying to, do the right thing and not be pushy, right? And if nobody's sort of dissembling that miscommunication, partners often feel very isolated together unnecessarily. So I think the next pieces of all of this are to move from what we do clinically to an evidence-based framework. Certainly we are trying to do that at the Dana-Farber in terms of sexual health intervention. And I don't have the time to talk about that in detail, but if anybody has any questions, we certainly can talk more about that. But the idea is that we need to build an evidence base for what works. Everybody has an idea of what works, but sometimes we're surprised that what you think might work might actually not work, right? And this is where we really need to be scientific about it. I also just want to throw this one slide in about clinical inquiry, because I know it came up yesterday, like how do you actually start to do some of this work, and the idea of what do you say, how do you ask. I will just put a plug in for everybody. I don't have a book to plug, I will say that, but I do have a checklist. So colleagues of mine through the scientific network that Dr. Lindau mentioned basically said, listen, we know that there are a number of kind of simple screeners or simple checklists for sexual problems in the general female population. How do we tailor something like that for women who have had cancer? The point of that checklist is that in the top of that checklist, one of the pieces says about vaginal health or sexual health, okay? So I think it's really important, whether you are working with patients who've had pelvic radiation, whether you're working with women who have had oophorectomy, variety of treatments, really important to also talk about vaginal health and sexual health. We notice this because often if somebody just gets a simple questionnaire that asks about sexual health and a woman is not sexually active with a partner, she may not answer because she doesn't know that actually the fact that she's having discomfort when she rides a bicycle or when she wipes herself after she urinates actually is part of the same genitourinary problem that's related to lack of menopause, lack of estrogen, okay? So being able to sort of clarify that the sexual health, vaginal health piece is related, very important. Okay, and then last piece, and I'll stop for now, is to say that we have to really build a process, right? That none of this can be done in a vacuum. Nobody's expected to become a sexual health or oncosexuality expert, but we need to think about a couple of main key points in terms of building this into your program wherever you are. So whether that's figuring out what the time is that you do this, when you intervene, when you ask, how this goes into a review of systems, what the access is that you have to information, who is your go-to person on the team? Is it a social worker? Is it a nurse? Is it a nurse navigator? You need to have that in your head before you ask. Because one thing which came up yesterday, which I don't think we really answered, is why don't people ask? Nobody's going to ask about sexual health if you don't know how to answer the question. Why would anybody ask about how it's going if the anticipation is that somebody's going to say, well, actually not well, and you're not sure what to do with it? So you have to have those resources ahead of time in terms of knowing what to offer. So building that referral network, building those resources, identifying who the pelvic PT is in your town, who the endocrinologist is or the urologist that you can go to, put it on a piece of paper, put it into your OMR, know the professional organizations you're going to work with. But I cannot stress this enough, that unless you feel confident yourself that you have a sort of a next step go-to plan, even if it's just where to refer someone to, it's understandable why we wouldn't ask about the problem. And last but not least, I will just say, join our community. So anybody who is interested in these issues around female sexual health after cancer, again, putting another plug in for the incredible network that Dr. Lindell started, the Scientific Network on Female Sexual Health and Cancer. We have a very cool website. We are now tweeting. And most importantly, we're having a great meeting at Duke September 25th, 26th, 2018, and very much hope that you'll come. Thank you.
So good afternoon. My name is Chris Nelson. I'm from Sloan Kettering Cancer Center, and I'm a psychologist there. Work a lot with men and sexual dysfunction after cancer treatments. So most of what we know about this comes from men with prostate cancer. Most of my talk will be focused kind of on men with prostate cancer. That research, clearly what we've learned from these men can be applied to younger men as well. There are no financial disclosures, and all of you may know this, but I always start my talks, not always, but usually I start my talks at least talking about prostate cancer a little bit. And so many men are diagnosed with prostate cancer. And so it's the most common type of cancer in men. So about over 200,000 are diagnosed yearly. That fluctuates a little bit, but generally about 200,000. And it's actually more common than breast cancer. So 1 in 6 men will develop prostate cancer. 1 in 8 women will develop breast cancer. And so I don't say this as it's a competition, right? What I'm just pointing out is that prostate cancer is to men what breast cancer is to women in terms of its impact and how many men are affected. Now, if I had to choose, I would actually rather have prostate cancer. And so because 90% of men who are diagnosed with prostate cancer are diagnosed in the early stages of the disease. And it's excellent survival rates. If you just look at the 5-year survival rate, it says 99%. If you look at ACS, it says approaching 100% in terms of a 5-year survival rate. Even if you look at the 15-year survival rate, it's at 76%. That's primarily because we have very good treatments that's diagnosed in the early stages. So we have a lot of men who are diagnosed. We have a lot of survivors. Men are usually diagnosed now at younger ages than they were 10 or 15 years ago. And if we think about early stage treatments, these are radical pelvic treatments. So surgery is radical prostatectomy, where they remove the prostate. And then if it's not surgery, it's potentially radiation, where they radiate the prostate. Those who select surgery tend to be younger and healthier. And there's a trend towards surgery because if you choose surgery and the prostate cancer comes back, that is your PSA level ticks up a bit, you can then move to radiation still as a curative treatment. So what we're seeing is younger men who are diagnosed with prostate cancer who are moving towards surgery and the implications that might have. And so although excellent treatments, basically all prostate cancer treatments impact sexual functioning to some extent. And so what extent? What are we talking about? And I don't want to focus on this a lot, but I just want to present these numbers. So these are data. These are some of our data. So this is back to baseline. That is, what percentage of men are getting back to their baseline erections? That is, their erections pre-surgery. How many men are getting back to those erections post-surgery? So we're looking at this at 24 months after surgery because there is a recovery time of erections after surgery. In general, we think about recovery at 24 months or 2 years. And if we look kind of at the top of this, when you look at the total sample, and then there's with PDE5 inhibitors and without PDE5 inhibitors, those are the pills to help erections like Viagra, Levitra, Cialis. If we look at the top of the slide, the total sample, 43% are getting back to their baseline erections with a PDE5, with a pill, 22% without a pill. And then if we look at those men just with good erections before surgery, so come in with good erections before surgery, what percentage are actually getting back to their baseline erections? And let's look at those without using a pill. So these are men, good baseline erections before surgery, without using a pill. How many are getting back to their baseline erections without using a pill after surgery? 16%. So only 16% of men will get their erections back to the to the baseline that they thought they were before surgery. And then if we just take their look and break this down by age, we go kind of in the lower part of the slide, those greater than 60 years old, how many men are getting back to their erections after surgery, their baseline erections? Only 4%. And so if we think about prostate cancer, a lot of men are diagnosed with prostate cancer, really good treatments, a lot of survivors. all treatments are going to impact sexual functioning. To what extent do they impact sexual functioning? To a great extent. Almost all these men, after these treatments, their sexual functioning will be implicated to some extent. And so really, I think really the question is, so what? I mean, why do we care? And should we care? Because here is what men hear, right, from others, right? So these are men who have had surgery or radiation for prostate cancer. Here's what they hear about their sexual functioning. Well, at your age, does it really matter? Essentially what they're saying is, you're old, does it really matter, right? So younger adults are looking and say, my God, you're 55, you're so old. Are you still having sex at 55? Does it really matter, right? Or 65, or 75, or 85, right? And so men here, it shouldn't matter because of your age. So in this one, so you shouldn't be upset because your cancer is gone, right? So they did something to treat your cancer. What are you concerned about, right? And then the one I like, kind of like the best is, well, you'll just get used to it. Don't worry about it. After a while, get used to it. Everything will just be fine. And so here's what we know now about working with these men and actually reading the literature. So it actually turns out men really like their erections and like having their erections. And so we know now from a number of studies that ED is associated with depression and depressive symptoms. So men who have ED are more likely to exhibit depressive symptoms and be diagnosed with depression. So also ED does not dissipate. That is, the ED bother related to ED does not dissipate. And we've actually looked at this in about 200 men. We've assessed them pre-surgery and out to 2 years after surgery. We assessed them on ED bother. That is, how bothered are you around your erectile dysfunction? So before surgery, many men don't have ED, so there's no bother, right? No bother. After surgery, the bother jumps up at 3 months. And then we track them out to 2 years. The bother at 2 months was exactly the same at 2 years. I didn't even have to compare those means because they were the same, right? Men are distressed after surgery, and then even 2 years out, the distress doesn't necessarily dissipate. And what's important about this is that part of the question about bother is it asks, has this impact your general happiness in life? So not just happiness in the bedroom, right, but just in life. And men report that yes, it does, because it permeates not only what's happening with them in the bedroom, but it permeates their life. They report that they feel less like a man. They report that their self-confidence is down. They report that they think about this and it's on their mind. And so also important in this is that you can imagine then there's just significant relationship difficulties that can come from this. And we can talk more about that in a little bit. But I just wanted to bring this point home and just a very quick description of a recent patient that I saw. So this patient, so I work a lot with men, so as men, he's 54 years old, and he's a former Air Force paratrooper. So he served his country well as a paratrooper, right? He jumped out of planes, did a lot of things. What his job was is he would send like the ordnance out or the jeeps or the things that they were sending out by parachute, and then he would like jump out after them, right? And then land and hook the parachutes and stuff when those things were on the ground. And so for his commitment to the country, he now has spinal stenosis. He seems to be in constant chronic pain, not only back pain, but hip pain and knees. He wears a back brace. He uses a cane. When I saw him in the waiting room, he kind of struggled to get out of his chair a little bit. He uses a cane to come and see me. So this is what he did. These are ordnance that he would push out of the plane, and he would, again, jump out on a parachute after them and hook these. And so he also has prostate cancer now. In 2016, diagnosed with prostate cancer, had a radical prostatectomy in mid-2016. He reports from that urinary incontinence and erectile dysfunction, and his PSA in 2017 ticked up, started to be detectable, and he moved to radiation treatment. And so he was referred to me from radiation oncology for anxiety around his prostate cancer. And so think about this. So this is a man who's in constant pain, back pain, knee pain, right, hip pain. So this is a man who has prostate cancer. Prostate cancer came back. He's had treatment. He doesn't know if it's going to come back again. And he has ED and urinary incontinence. So he talked to me, and he really kind of talked very eloquently about like what was the hardest thing for him to handle. And the hardest thing for him to handle through all of this was his coping with his erectile dysfunction, right? Out of all these things. And you sit back and think, well, wait a minute. Why is that such a concern for him? Look at all these other things that's going on. But it's kind of a good example how men kind of cope and potentially deal with these things, that ED is something that permeates their life. It's something that impacts them kind of at the core of what it is to be a man. And so even though there's all these other problems, a good example of the distress that this causes is that ED is basically kind of the main concern for him, right? And so ED also causes relationship issues and concerns. And so I often call this, and when I talk with couples and work with couples, I always kind of talk about this as she doesn't understand, he doesn't understand. And this concept of, the concept of men are from Venus and women are from Mars, or women are from Mars or men are from Venus, whatever that was, right? So this is really kind of where they're communicating in different areas. And so this is very heterosexually focused. I will say if it's a gay relationship, it's generally about the same. But essentially what happens is that she doesn't understand why the man's so upset about his erectile dysfunction. She's thinking, well, listen, we treated your cancer, your life's more important. If we're thinking about sexual relations, there's so much more we can do than penetration. She's probably thinking it wasn't my favorite part of it anyway, right? And so maybe I'm a little happy that it's gone. And so she doesn't understand why he's so upset. And then he doesn't understand why she's not upset at all, right? And he just doesn't get it why she's not concerned. And so you have them talking like this, and Sharon talked about really the benefit of having them come together and talking about these things so at least they understand their differences and try to develop some common ground. The other thing that happens, and Sharon talked about this, is this sense of performance anxiety. And so there's an anxiety ED cycle that, the anxiety about entering a sexual situation for a man starts to build if he's not confident he can get a firm erection. And it starts to kind of then have a cycle where he's not confident, he moves into a sexual situation, he's anxious. It turns out adrenaline from anxiety is the most potent anti-erection agent there is, right? He starts worrying about what's happening in erection. Is it going up? Is it going down? He becomes nervous. He's taken out of the sexual situation. He's not enjoying it as much. He's not getting an erection. So it increases for his partner, because his partner now is worried and concerned about the anxiety that he's experiencing. And so the partner, he or she, is not exactly sure how to cope and deal with it, as Sharon talked about. And it can lead to basically behavioral and emotional changes for both the patient and the partner in the couple. So the good news in all this is we can help. In terms of erections, we have excellent treatments for erections, right? And I think, Jeff Arbaugh was here yesterday, I think went through all these types of treatments, and they work. They generally work really well. So I started working in this field probably about 12 years ago with a sexual medicine professional, John Mulhall. And so he would say, he's like, Chris, I can get their erections back. Getting their erections back is not the problem. It's actually having them use these erectile function aids and kind of work into their sexuality. That's the difficulty. And so we've got great treatments, right? But unfortunately, we have no good data which suggests that men avoid and drop out of ED treatment. And it has to do kind of a lot with this anxiety cycle that we talked about. And so just some of the data here, men drop out of treatment. So 50% of PDE5 users, these are the pills, actually do not refill their prescription. We know that these are very effective. We know that generally it's working for men, but 50% of men don't even renew their prescription first time. 50% of injection users are not using injections after a year of starting. So self-report injection data, this is their self-report. So 60% of men continue using injections at 4 months. This is our data from our clinics. Only 33% at the rate suggested for rehabilitation. There's a concept of rehabilitation after prostate cancer surgery. Jeff might have talked about this a bit yesterday. It has to do with the fact of you want to keep the penile tissue healthy as the nerves are healing. It's kind of like a use it or lose it type of a thing. And there's a specific kind of protocol for that. Only 33% of men are actually following that protocol. If you actually count injection use, so the middle bullet is self-report. If you actually do a more objective report, that is you count the syringes. That is, we know how many syringes they're prescribed. We can count the syringes that they didn't use, how many they're actually using. they're injecting it less than 1 time per week. In terms of rehab, they should be injecting 3 times a week, and only 10% are injecting it since the rate suggested by rehabilitation. And so some of my work has focused on kind of understanding more about this process, about why men are avoiding. And we've already talked about this notion of anxiety cycle, but my qualitative work has focused on kind of really fleshing this out a little bit more. And essentially, there's a cycle that starts, and there's disappointment and shame related to ED. So a man thinks to himself, I'm not a man. He thinks to himself, my partner's going to leave me. He thinks to himself, I'll never be able to get it up again or be in a sexual situation again. This leads to distress and depressive symptoms. There's fear and anxiety of entering a sexual situation without being confident that you're going to get a firm erection. And so when you ask men, what's it like for you to enter into a sexual situation when you're not confident you're going to get a firm erection? Men will say, it's fear. It's fear, doc, basically is what they'd say. And so they talk about using the injections. Yes, they're effective, but they can be a turnoff. The whole process is humiliating. Whether you need to use a pill, whether you need to use an injection, the whole process of even have to do anything is humiliating because they never had to do it before, right? And this leads to avoidance. If you're nervous and anxious and you dread something, and if you're thinking about doing it that night, okay, I'm going to use an injection, I'm going to try, but the man starts to get really nervous, starts to get really anxious, starts to dread it. The quickest way to get rid of that anxiety is to say, I'm not going to do it tonight, to avoid it. It works really well. It's an instant mechanism. The anxiety is relieved instantly as you avoid it and put it off for another occasion. So that's one example here in sexuality. All of you may be familiar with these examples in your own life about where you're anxious about something and put it off, right? So although that works really well in the short term, it doesn't work well in the long term. And that men think about, well, now I'm missing or I'm losing out on a value life experience, that is entering like a sexual experience, being able to have erections again. And this leads to increased frustration, depression, and distress. And so this is a stereotype, right? This is a stereotype. So, and I just want to point out the top part, right? That stereotype is that men are always in the on position, right? That they're always ready to go. In terms of libido, they're ready to go anytime, anywhere. And I would suggest maybe if a man doesn't have difficulty with erections, potentially that might be true depending on the man, right? But if a man does have difficulty with erections, he's not on the on position anymore. As a matter of fact, he's on the off position. And there's this sense of anxiety and distress and fear that goes into moving up into the on position. And we need to do more than just hand out erectile function aids. We actually need to help men in the process of using these and get back into sexual relations. And so really kind of the focus, we hope, and what, I support is this notion of a combined therapeutic approach, and Sharon talked about this as well. So it combines medical treatments for ED with a psychological treatment. The goal is to help the patient and couples successfully use the medical treatment. So, and I've done a lot of work with a type of therapy called acceptance and commitment therapy. It does sometimes integrate mindfulness techniques, which Sharon talked about. So, and really talks about exploring the importance of sexuality with the patient and the partner. Accept short-term anxiety. We know you're going to be nervous. That's okay for the long-term benefit of goal of being able to enter into sexual situations again, being able to have the confidence to do that, to hopefully integrate with your partner again. Diffuse anxiety and frustration. We discuss and we highlight the potential barriers, and we talk about commitment. ACT increases compliance with a penal rehab program. So I have data, it's not here in this slide, but I have data which suggests that. Now I'm running a larger study to suggest that as well. And so this is actually another one of my favorite slides. So this is at like a Safeway, like a grocery store, and it's supposed to say, pen is broken, please use finger. Right? So, and why this is one of my favorite slides is that, just thinking about this, like if a man's penis is broken, he doesn't want to use his finger. He wants to figure out how to fix that penis, and we have good medical treatments to do that, but we need the psychological approach to integrate to help him get back into actually using that. And so how do you talk to patients about this? Or what are some suggestions or just some quick guidelines in talking with patients? First, educate is important, but focus and explore the importance of sexuality to the patient. Instead of starting with the problem you have ED, focus more on why is it important for you to get your erections back? Tell me about the value that that has in your life. Acknowledge that there's short-term anxiety with this. Kind of forecast this for patients. You're going to be nervous, you're going to be stressed, you're going to be worried about this. That's okay. What's important is a willingness to enter into a sexual situation even though you're anxious about it. Right? Focus on the long-term goals as opposed to the short-term anxiety. Discuss and highlight barriers. Ask them what will get in the way of using the treatments. Predict that they will find excuses. You know, I often talk about it. I know you're going to find some excuse. You're going to be finding excuses like you're too busy, you're just a little too tired, right? Something always comes up. And it probably has to do more with anxiety around actually trying these treatments and entering a sexual situation than those real barriers. And then talk about a commitment. And so this is my last slide. And so this is by Patrick Walsh. So I work a lot with men with prostate cancer. So I talk to a lot of urologists. So Patrick Walsh is probably one of the most famous prostate cancer surgeons there is. He basically developed nerve-sparing surgery. So when I present this to urologists and Patrick Walsh's name up there, like everyone stops and listens. So, and I know that probably not many of you are urologists, but I think his quote is important. I always kind of generally like to leave with this. And the two most important things you can do as a physician are to listen to your patients and to care for your patients. And ultimately, I'm asking you and challenging you to take the time to listen about these sexual concerns and take the time to care enough to hopefully help them, either refer them to appropriate services that would be both medical treatment to help with the erections and then also some type of psychological, sex therapist, social work support to help men use these treatments. So thank you very much.
So one question I had was, Sharon, you mentioned at the beginning of your presentation about patients coming with a sexual history and a sexual experience. Well, what about the very young patient who comes with no sexual history or experience? You know, how appropriate and maybe what kind of counseling terms would you use to address anticipatory worry about not being able to be a sexual being in the future?
So it's a great question, and I was just speaking yesterday with Dr. Lindsay Frazier and Natasha Frederick, who are both pediatric oncologists that are here, about this very issue, because I think that when you say very young, I assume you mean adolescent patients,
right,
or,
yeah.
you know, because we certainly know that, you know, psychosexual development is often disrupted by pediatric cancer treatment, and young, you know, adolescents, school-age kids through, you know, adolescence, you know, have treatments that are going to have an impact. And I think that this is where I think it can be very helpful to take a page from the adolescent medicine playbook, which is that, you know, we know there are ways to speak to teenagers and adolescents about sexual development. We also know that it is probably helpful in the same way that you all have probably a pretty sophisticated sense of how to speak to parents about fertility with kids that are not going through it at the time, right, but that may be looking at something that's going to be coming up later. I think we need to sort of develop a language around talking about sexuality in the same way. So this is to say that, you know, having parents be able to, I mean, first of all, let me just sort of step back and say, most parents don't really know how to talk to kids about sex, right, like under the best of circumstance. I mean, I should say most. Many parents, you know, you hand someone a book, you know, whatever. It's not like the easiest thing to do. But I think that being able to sort of give parents, first of all, giving parents language about how to talk to kids about, you know, expectations. So thinking, for example, about what it means if you have a girl that is not going to who has high-dose chemotherapy and is simply going to need estrogen replacement from a young age, for example, is not going to sort of go through puberty in the same way, boys or girls. It's just important to be able to think about the kind of language which is developmentally appropriate and to talk about the ways in which their bodies are similar and different to same-age peers, and really to sort of think about how to, again, more sort of less say something but ask questions, because I think in the same way that we don't we don't talk with patients, we don't listen to patients, I also think lots of times it's less about finding the exact language in terms of how to say everything, but what I'm sort of struck by is more like saying to that 13-year-old or 15-year-old, wondering if this is something that's on your mind, wondering if you have any questions for me about what this is going to mean as you are, growing up and dating, or, not getting your period, or thinking about puberty. And it's okay to ask and elicit from those adolescents what their concerns are. And then I also think to be able to sort of, again, have a person that they can talk to. So whether that's an endocrinologist, whether that's a pediatric social worker on the team, I mean, thinking about who the person is that's going to be able to speak to that young person in a developmentally appropriate way. Again, I think we've, again, this is not my area, it's not fertility, but I would imagine that you've had to develop a kind of a language to do that, right, that's developmentally appropriate around fertility. I think we need to do the same thing around sexuality.
So, and I would just comment that, it's hard to have the conversation with adolescents and young adults, and it's even hard to have the conversation with older adults, really. But I think kind of over time, bringing it up consistently over time is really helpful. I think kind of the first time, second time, the third time you bring it up, the patient might not share anything. But if you bring it up consistently over time, it normalizes the discussion, and it helps you kind of be more comfortable with it. And that then helps whoever that is, however old they are, to start talking about their sexuality. It starts talking about their questions and their concerns.
I also just want to say that, again, thinking about some of the really interesting qualitative work that Dr. Frederick and I have been doing, this notion of psychosocial disruption, right? This idea of psychosexual disruption, where, adolescents really may have real questions around, what does it mean when, you're going through treatment for, I'm thinking about a patient of mine that I saw who was treated for a sarcoma at the age of 16, and when her friends were doing what 16-year-olds do and dating and everything else, she was going through a very aggressive cancer treatment, got to college and had, forgetting dated, it was not even on her radar during the time that she was going through kind of adolescence. And it was interesting, when she came to see me, she was just starting graduate school, and she said, I know everybody and she was about 22, and she said, I know everybody talks about sex and sex and sex. I've never kissed a boy. When my friends were doing all the kind of exploring and sort of sexual exploration and just what normal adolescents do, that's not where I was. So what does that mean to start that now? And how do I tell someone when at the age of 22 or 23 that I actually feel like I'm 13, in terms of the feeling of butterflies and worries that I have no idea what I'm doing. So the good news is I can say she's married and just had a baby, which is a pretty big deal. But when I think about that now, when she first came to see me, in terms of the kind of the sort of sexual development piece, the sort of the work that she had in front of her as somebody in her 20s, where she felt like, compared to same-age peers, she was on a different planet. I think those are the kinds of places and spaces that we need to open up to be able to listen to our patients as much as tell them what they need.
And I have another question that this came up at lunch, and it seems appropriate to ask now. Are either of you aware of existing tools or instruments that measure distress or concern about sexual functioning that are appropriate for the adolescent young adult population?
So I think the short answer is not really. I'm looking at Natasha, is that, so I don't, the idea of a validated instrument to measure psychosexual distress in cancer survivors that are adolescents, no. But, I think that there are On the other hand, I think that we actually have a lot of good ways to sort of measure distress in general. I think there are ways to ask about sexual disruption and sexual development in general. And I would say that, that is not there's not a validated measure for that. And at the same time, I think that we don't need that measure in order to, at the sort of the basic clinical level, to start to make inroads into the into inquiry.
Hi, Megan Bowman-Kersey from Moffitt Cancer Center. Thank you both for the really important work that you're doing. It was very interesting. My question was, Dr. Barber, you had a tool, a checklist for women, and I was wondering if there is a similar kind of checklist for men.
Crystal, I'll let you take that.
So yes and no. There's a number of instruments for men that you might use in terms of assessing kind of sexual functioning, and it would really depend on kind of what you want to get at. And so in terms of erections, there's good measures for erections. We have some decent measures for things like distress, a good measure for things like sexual self-esteem and relationship confidence. And so there probably is a checklist similar for men.
Right.
But there are also very good instruments that are well validated, widely used to assess sexual functioning, also distress related for men. And so, yeah.
I mean, we'll say certainly, the PROMISE initiative, which is sort of an NIH-funded initiative for sort of PROs around sexual health and cancer survivors, has a one-item screening check measure, sort of for men and for women, which is essentially premised on some relationship or sexual activity. But that's, again, sort of a one-item, and you can look that up. The PROMISE has a one-item screening measure.
Thank you both.
Yep.
I just have one question on that. Would you comment on whether using a questionnaire or screening tool for a chronic medical illness would be appropriate, similar, sufficient crosstalk for cancer patients?
Oh, that's interesting. I guess it depends on what it is you're trying to assess. So can you say a little more about
sexual, if you're looking for screening for sexual dysfunction,
Yeah.
could you use a questionnaire that is used in patients with chronic medical illnesses?
So I guess
There isn't any, right?
Sure. I mean, I guess it depends on what the specific aspect of function is. So if you're looking at erectile function, that's probably going to be.
Sure. So the IAF is the most common and widely used measure of erectile function. It has a separate domain for erectile dysfunction or erectile function. And so for men, I think that's a really good approach, actually, is assessing on a consistent basis. And so for men, there's definitely instruments. For women, there's instruments, and we can kind of talk about specifically what that is. But conceptually, what's happening then is you're assessing on a consistent basis when the patient comes to your office, and what you're doing is you're normalizing that experience for the patient. You're normalizing that they may have difficulty, they may have problems. You're normalizing the language, and you're normalizing that you're going to ask about it. And then it becomes easier for the patient then to talk about it or bring it up, because after the sixth time they've seen you, they've filled out this measure, and they're finally going to grab the courage to say, yeah, I'm having problems with my erections. Or my libido is really down, and I didn't know I could actually talk with you about it, but since I fill out these questionnaires all the time, I guess I can. So I think that approach actually is really important, I think works well.
The only thing I would say that I think differs for women, honestly, is that, so depending on what the chronic illness is, I think typically the sexual health question, sort of whatever one or two items is, typically about, it asks about pain with sexual activity, or maybe something about dryness, which are very sort of relevant, to women's sexual health. But I think you have to look at the setup for the question, because I think for women in particular, a number of these sort of short items or measures have to do with sexual activity. And if you don't specify for women the difference between vaginal health and sexual health, often women are having vulvovaginal discomfort or pain that is not related to sexual health that you might miss if it's just a sort of a sex question. Does that make sense? So I think that's less about the the parallel or the congruent illness, and more about the piece that if, for women in particular, if you don't clarify that you're asking some kind of questions that's sort of symptom-based, whether it's with or without sexual activity, or with sexual activity with someone or by yourself, but some way that sort of gets at that other kind of vaginal health piece. I do think that often we underdiagnose and miss issues that need to be addressed.